Hi, my name is Dr. Leppla. I'm going to be talking about stuckness in care, a need for innovation in the evaluation and management of catatonia. I'm talking to you from Johns Hopkins Bayview. Next, Gregg Robbins-Welty will talk to you about catatonia in the palliative care setting from Emory University. Amanda Plein will talk to you about catatonia in incarcerated individuals from Northwell Health. And Soumya Sivaraman will talk to you about the treatment and assessment of catatonia and some legal considerations. I have no disclosures with regards to this presentation. My case is of a 78-year-old man who was admitted who has dementia, who was presented to the hospital with failure to thrive. He was admitted to the hospital for antibiotics and was found because he was found to have a UTI in the emergency room. Per family, he had lost 30 to 60 pounds in the past 6 months due to not eating. Psychiatry was consulted because there was a concern for catatonia. On exam, the patient was bent over and in the fetal position, and he did not make any eye contact. The Bush-Francis score was positive for immobility and stupor. He had virtually no interaction with the external world. He was mute. He spoke less than 20 words in 5 minutes, and when he did speak, his speech was very garbled, and he had no oral intake for many months, according to his family, and certainly not while he was in the hospital. However, when I saw him, I thought to myself, how can we differentiate delirium versus catatonia? Hypoactive delirium, you can have a lack of interaction with the outside world. You can have somnolence and poor PO intake. And in hypokinetic catatonia, you can have mutism, stupor, refusal to eat and drink. And those symptoms seem to blend together. So how do you differentiate one or the other? Does having one mean that you can't have the other? I continued testing him, and aha, his muscle tone might have told me something. Rigidity and negativism. He was rigid, and there was possibly some negativism on exam. He seemed to resist what I was doing, some moderate resistance, and he was frequently moving contrary to what I was telling him to do. I had my clue. It was the rigidity that would push this towards the catatonia diagnosis, and I would start my Ativan trial. However, I then looked deeper into his chart, and in his chart review, it said he had had a prior stroke. Now, I know from my neurology clerkships that patients with prior strokes have spasticity. So that negativism and rigidity that I thought was from catatonia, could that actually be due to residual deficit from a stroke? And could I not include rigidity in his Bush-Francis score after all? I was really concerned. What's a diagnostic CL psychiatrist specializing in catatonia to do? Now I felt like we had come to a fork in the road. Should we do an Ativan trial? I was trepidatious about an Ativan trial in a patient with possible hypoactive delirium because Ativan can further sedate the patient, make him less responsive, less likely to engage in PT, and more likely to end up in a nursing home. However, if we did not do the Ativan trial, he would likely remain as he was, losing weight with no answers. Now, if I were to look at the DSM-5 for clarification, he would meet clinical criteria for a catatonic disorder due to a general medical condition due to stupor, mutism, and negativism. However, I would see that the DSM-5 does not recognize the co-occurrence of delirium and catatonia. As it says, catatonia must not exclusively occur during the course of delirium. However, it is possible that this exclusion may not be well-founded. There's been increasing writings and evidence by people that we know and love in the ACLP that delirium and catatonia actually can and do coexist. In the study on top, do patients of delirium have catatonic features? An exploratory study, it actually found that up to 30% of patients with catatonia also have delirium, or the reverse. In catatonia in the ICD-11, the ICD-11 offers the first set of catatonia diagnostic criteria, which delirium does not exclude catatonia by default. Instead, the ICD-11 requires only that the catatonic features not be, quote, fully accounted for by delirium or the effects of a medical condition, medication, or substance. And in the bottom study, delirium and catatonia in critically ill patients, it points out that delirium and catatonia often do coexist. Here are some statistics about delirium and catatonia. In 100 cases of catatonia, 20 will be due to a general medical condition. The other 80 will be due to schizophrenia or mood disorders, and they will present with the grimacing, the waxy flexibility that are all very nice and neat, and we can diagnose easily. But of those 20 patients that have a medical condition, up to 2/3 of those will be in patients with neurological injury. So if you have a patient and they're catatonic due to a medical condition, you really need to think about neurological injuries like encephalitis, stroke, dementia, delirium. And 30% of patients referred for catatonia in the general medical population will have comorbid delirium. Now back to our patient. Was his rigidity better explained by a neurological injury? Should neurology be consulted for additional ideas if these neurological conditions so often happen in catatonia? Long story short, in real life, we did not consult neurology until much later, and we did not get an EEG when we should have. We did an empiric Ativan trial, and his rigidity got somewhat better, although it could have been due to an improvement in spasticity with lorazepam. He may have also started eating more with assistance in feeding, but that may have been because we were educating the nurses and sitters that he needed a lot of assistance in feeding. We ultimately stopped doing the IV lorazepam because the results were inconclusive. When neurology later saw the patient, they wondered about a Parkinson's plus syndrome. In these puzzling cases, an EEG might be your best friend. We do know from our training as consult psychiatrists that when a patient has delirium, there is widespread cortical dysfunction associated with diffuse and symmetric slowing of electrical activity on EEG. You see in the picture on the right, there is progressive slowing of the EEG and progressive hepatic failure. This is from the book Psychiatric Dementias of Medical Practice. The only exception to that is alcohol or benzo withdrawal are associated with fast activity on EEG. Therefore, we propose this workaround. When you have signs and symptoms of catatonia that are not better explained by a neurological disorder and delirium is considered and managed, consider getting an EEG. If the EEG is negative, meaning no global slowing, which would indicate delirium, then consider an Ativan trial or ECT. Thank you for listening.
Hello, everyone. Thank you so much. Thank you so much to Dr. Leppla for her presentation this morning. My name is Gregg Robbins-Welty. I'm an internist and a psychiatrist and a palliative medicine attending at Emory University, and I'm really looking forward to talking to you all about our need for innovations in catatonia evaluation and management, specifically in the hospice and palliative care setting. I wanted to start by saying I don't have any disclosures. And maybe we could start by just acknowledging that maybe your first instinct in hearing that I'm going to be talking about a hospice and palliative medicine setting in catatonia is sort of confusing and not something that we talk about very often. And I hope that I can talk to you all about why I think it's really important and that we actually see this quite frequently. And there is just an absolute dearth of data and in some ways clinical experience to help guide our decision making in this setting. So I wanted to start with some cases to sort of get us framed about why this is important. So these are real cases that I saw in a palliative medicine context. So Miss A, she's 85. She has pretty advanced dementia without behavioral disturbance. She needs some help with her ADLs at baseline. She was brought to the emergency room because of a change in her functional status, including some new agitation and social withdrawal and a decrease in oral intake, and her medical workup was kind of unrevealing. And so palliative care was consulted because perhaps this is progression of her dementia, this is terminal delirium, and would it be right to put in a feeding tube for this patient? And ultimately, what happened to her is that she had a positive Ativan challenge, and she quickly returned to her baseline cognitive and functional status. Thereby, treating her catatonia led to both improved quality of life, but also life prolongation. And so the lesson in this first case is that catatonia is commonly masquerading as other clinical syndromes, especially with folks with perhaps a fragile neurologic substrate. And so this can masquerade as delirium, advanced dementia, and we have to be really careful thinking about catatonia on the differential diagnosis. Another case that I saw, Mr. B is a 56-year-old gentleman with bipolar disorder that had recurrent admissions for both mania, but this time he was admitted for depression with catatonic features. He subsequently developed an aspiration pneumonia and acute hypoxic respiratory failure. He was transferred to the ICU where he was intubated and had a very tenuous um, clinical status. Psychiatry consults saw the patient and felt like he still met criteria for catatonia and had recommended ECT to be delivered in the ICU, whereas the ICU team were uncomfortable with that plan and were worried actually about his bigger picture prognosis. And so we were consulted in palliative care for goals of care around ECT, managing catatonia, and the bigger picture. And to cut to the chase, the family actually ended up electing not to pursue ECT in this case, and we redirected care towards comfort care and managing his symptoms at the end of his life. And the lesson here is that catatonia is highly morbid in and of itself. Our treatments, especially ECT and some of the medications that we use for catatonia, carry risks, and prognostication can be really challenging, as can medical decision making when you have catatonia as well as a complex medical problem that's threatening life. And the last case is Miss C, who's a 90-year-old female with really advanced dementia. She was already enrolled in hospice services at home. She had really poor PO intake. She had a FAST score, which is the means by which we determine whether a patient is hospice eligible in the setting of dementia. And she was nearing the end of life, but then she developed a pretty acute change in her status and raised the question, is this catatonia or is this terminal delirium? And ultimately, she also had a positive Ativan challenge and had some improved rigidity and a little bit of improved communication at the end of her life. And ultimately, we avoided dopamine blocking agents, which are pretty standard as part of a hospice order set when agitation occurs at the end of life, and avoided that for the purpose of trying to keep her catatonic symptoms at the front of our minds when caring for this patient. And there are a lot of lessons here, but one of them is that treating catatonic symptoms, even at the very end of life, may improve an end of life experience, even in hospice contexts. Though, of course, you have to take into consideration prognosis, risks and benefits, goals of care, these sorts of things. I think it's important to know just right off the bat that about 90% of patients actually pass away meeting criteria for delirium. And I contend that many of these patients would also qualify for a diagnosis of catatonia based on our current criteria, which I'm giving you some foreshadowing that I think some innovations could be useful. I think having our similar language is also really useful. And so, very briefly, serious illness is the term that we use to describe the illnesses for which palliative care is standard of care. It's a life-threatening condition which imposes a symptom or caregiver burden. Palliative care is a medical specialty, but also interdisciplinary team. We rely heavily on social workers and APPs and chaplains and pharmacists and a very diverse interdisciplinary team to care for patients with serious illness. Palliative care is not hospice. Hospice is palliative care, and so they are different. And so palliative care can be given alongside life prolonging and even curative treatments, whereas hospice is specifically, at least in the United States, specialized medical care for patients with a prognosis of less than 6 months. And typically those patients are foregoing invasive life-sustaining treatments like intubation or rehospitalization in general. I wanted to share that the way that we think about palliative medicine is that it's grounded in some values and some important concepts. Those include prognostication, thinking about what this illness's course is expected to be, and not only just in time, but also in impact on the patients and their families and caregivers. Values-based decision making. You might have heard the phrase goals of care. This is really the process by which we understand what matters most to patients and families who are facing serious illness, and it helps us clarify values, fears, acceptable trade-offs, which is really the next thing that palliative care is based off of. Everything we do in medicine and life, I would argue, is based on trade-offs. And so everything we can do in medicine might be aimed towards life prolongation, or it might be aimed towards comfort. And often those things are in conflict. And a risk-benefit calculus is important to that when we are thinking about every medical intervention that we're doing, from a medication to a hospitalization to a surgery, et cetera. Advanced care planning has less relevance, I think, to catatonia care, but There is growing literature on psychiatric advance directives when we're thinking about people planning for medical care they might anticipate coming ahead. And again, just to emphasize that we're highly dependent on our really skilled IDT team and trying to provide whole person and caregiver care. Now, the point that I'm trying to get here is that we know very little about all of these things in catatonia. We know very little about catatonia prognostication in the setting of serious illness. We know very little about the values that patients with catatonia or their caregivers may lean on when making medical decisions. We know very little about the trade-offs. We know okay about the risk benefit, and we certainly know very little about advanced care planning. And just to hit this point home more clearly, how common is catatonia in palliative care settings? And how impactful is it? And if you look at the literature, we would say we have no idea. And we don't. We don't know how common catatonia is in a palliative care setting. We don't know exactly how impactful. I would argue, anecdotally, we can talk about these things. So first of all, we know that somewhere between 3 and 20% of ICU patients meet criteria for catatonia. And so by that, you might suspect that catatonia is pretty common actually among patients with serious illness and in palliative and hospice settings. I can tell you anecdotally, I personally am consulted for end of life discussions for patients that are reversibly catatonic quite frequently. In fact, I would say I've seen catatonia in a palliative care context more often than I saw catatonia in a psych context because it relies on the teams to recognize it and then call psychiatry, and instead they're calling me. I also think that I can contend that catatonia is often occurring in the setting of serious illness, and that catatonia can even herald serious illness, meaning patient presents with catatonic features because they have a new cancer, a progressive cancer, a new brain metastases, new seizures, a new serious illness of some kind. And then again, as I mentioned before, given that delirium is so common at the end of life, I actually think catatonia is quite common at the end of life as well. Thinking about the impact, we know catatonia is broadly impactful to patients and to families. Of course, there are the medical complications associated with catatonia, DVTs, pulmonary emboli, malnutrition, bed sores, these things that lead to then mortality and morbidity in and of itself. Catatonia directly impacts patients' ability to communicate. Therefore, it has an impact on their decision-making capacity. Therefore, it has an impact on their autonomy. And I would argue, therefore, has also an impact on their quality of life. Taking care of patients with catatonia imposes a caregiver burden. And there's actually quite a few studies that show that catatonia has a psychological toll, and that patients qualitatively that have liced their catatonia and come out describe the experience of being extremely fearful, and that they were scared, and that it had a major psychological impact on them. And so for all of these reasons, I would argue that catatonia in and of itself is a serious illness for which there could be a role of palliative care, both in prognostication, medical decision making, goals of care, risk benefit analysis, and our interventions, et cetera. So I think that there is a bridge here between CL and palliative medicine. Thinking more about the impact of catatonia, I just wanted to hit home that I personally have seen quite frequently catatonia being mistaken for other conditions, including progressive dementia, the dying process itself, terminal delirium. And I think we all need to be really worried about diagnostic nihilism. It can be the cheapest and path of least resistance to send patients to hospice instead of thinking broadly about, well, whether we should get ECT for this patient, for example. And I think CL psychiatrists are particularly well positioned to be part of that conversation and to advocate for patients. If you are mistaking the diagnosis for something that it's not, that is going to obscure the prognosis and really risks misdirecting goals of care conversations and having premature decisions about hospice referral or withdrawals of treatment. I wanted to emphasize this paper that we wrote last year where we went back through 5 years worth of patients that had both ECT referrals and palliative care referrals. And the most common indication for ECT among these patients was catatonia. But what's interesting is that the most common patient that we saw in this cohort was patients were referred to palliative care for goals of care conversations about feeding tubes. Palliative care came in and said, yeah, I think this is probably progressive dementia or terminal delirium. ECT or CL came in and said, I wonder if this is catatonia. And the patients that got ECT walked out of the hospital. And so I think that this is pretty important, and I think really emphasizes why we need more studies and to learn more about how can we think through these cases. And so just kind of again bringing up more questions than answers here, but really emphasizing our need for innovation. Again, we need to understand the impact of catatonia on patients, caregivers, clinicians. Do patients that get treated for catatonic symptoms at the end of life actually have an improved end of life experience? We don't know, and it would be really great if we could study that. We need better validated and assessment tools for patients that fall outside of the typical patient population for which the Bush-Francis is validated. We need to be able to differentiate catatonia from terminal delirium and irreversible processes. We need to think more about this prognostication, like how do we tell the difference between a reversible catatonia and a heralding catatonia? I just came up with that term here, but what I mean is the catatonia that shows up in the setting of a new irreversible process, and predicting treatment responses. Thinking about how do we balance the risk and benefits of ECT for medically complex patients. So anyway, there's a large opportunity for CL psychiatrists to advocate for vulnerable patients, advocate for accurate diagnoses, and really advocate for appropriate values concordant treatments for our patients with catatonia. Really grateful for your time and happy to talk more about this work. My email is here on the screen. So thank you so much, and I will pass it off.
Hi, I am Amanda Plein. I am a current fellow in CL Psychiatry at Northwell Health, and I'm going to be talking about diagnostic and treatment barriers of catatonia in the correctional setting. I do not have any disclosures. What I would like to say is that this is through the lens of my experience rotating as a PGY4 at the Tarrant County Jail in Fort Worth, Texas, during my residency, and my experience does not necessarily, represent every correctional system, as each correctional facility has their own protocols and processes. And even when I'm presenting today, they may have changed their policies and protocols since I've been there. So. In general, when we look at psychiatric care in the correctional system, the correctional system is the single largest provider of mental health care services in the US. And the percentage of individuals that have mental health illness is much larger in correctional system compared to the general population. I believe it's 44% in jail and 37% of individuals in prison have mental health conditions versus about 18% of the general population. And with that, we end up treating individuals that would usually be seen in a variety of clinical settings, ranging anywhere from voluntary outpatient clinic type patients to patients that would usually be seen in like an involuntary psychiatric hospital. And it's quite difficult to implement efficient and equitable mental health care services in the correctional setting. And ultimately, this unfortunately results in less than ideal care for particularly those with severe mental illness. When looking at catatonia in the correctional setting, I'm going to go over a few issues with diagnosis and treatment, including triage, psychiatric interview, lack of supportive information, issues with continuity of care, limited access to ECT, and then sort of overlapping between diagnosis and treatment would be refusal of care and what I like to call challenges of that event challenge. So initially, everything starts with triage. How is it decided that individuals are going to be seen by mental health? In the jail that I rotated at, there's a general health intake when an individual is arrested and goes to jail. And this mostly focuses on your general medical history and also infectious, disease sort of history, but there is a portion about mental health. And the jail where I was at in Tarrant County would access databases to see if an individual is taking psychiatric medications, in particular if they filled a psychiatric medication within the last 30 days. If appropriate, they would restart those medications and they'd be kept put on a list to be seen by a psychiatric provider. But sometimes those medications wouldn't be available at the jail, or something like a controlled substance, highly unlikely that they would continue that. And besides that, who else would be seen by psychiatry? Anyone can request, any individual, they can put in what's called a kite, or a request to see a medical or psychiatric provider, request by staff, such as a correctional officer, social worker, also individuals who would be in protective custody, These individuals are placed there due to risk of danger to self or others, or not functioning adequately in general population. And I'll get to what I mean by general population later. And those individuals, part of the initial process of being seen is to determine if staying in protective custody is still appropriate, because you can sort of think of it analogous to like when someone's on a one-to-one in the hospital, they're sort of at a higher level of care. And so these individuals, there's a limited number of single cells that a jail has. So they want to make sure that, someone who's in that single cell does need to be in there, and that they are someone that's appropriate for that. And then, of course, someone who's incompetent to stand trial would also be seen by psychiatry. The time that they're seen varies really depending on what sort of category of triage and that they enter, and then the urgency. Now, general population, I want to give some education just about what it looks like in a correctional setting, because I didn't know really much about this before I rotated. But this is sort of what a general population would look like, which there are individual sort of cells. There might be one person or two people in these cells, and then a sort of general area. And during the day, sort of like the doors are open like this, and individuals, can go in and out of their room. And in this setting, there's anywhere from like 20 to up to 40 inmates, and there's only one correctional officer per this entire space. At least again, where I was rotating at. So usually what we would do is we would go on to these units, or what they would call blocks. You'd have to go through a succession of like multiple sort of metal doors that are the COs have to electronically sort of remotely open for you in order to get onto the block. And then we would, they would call for an individual to come see us. And not really pictured in here, but sometimes there's like a little area to the side where we can kind of get some privacy to talk with the individual. But this is how we would be seeing an individual in the general population. Another type of general population is sort of dormitory style. So as the name goes, this looks sort of like a dorm. You have a bunch of bunks, and it's in one area, just like this picture has the metal bars. Where I rotated also had metal bars for this dormitory style. And as you can see, there's like a shower, toilet, things. So everything's all in that area. Basically, we would go through again a couple metal, big security doors, and then again call for an individual. They would come up to the bars and talk to us. So as you can see, someone is sitting right next to them. There's not really any room for privacy with that. And then a single cell, this is what it might look like from the inside. Again, these are usually individuals that are in protective custody. They are in this cell 23 hours per day and are supposed to be allowed out for 1 hour a day to shower and things like that. But this is what it looks like sort of on the inside. And then from the outside, this is what the doors look like. The reason I bring this up is because when you would go see an individual in the single cell, you would have to talk through this big metal door. So essentially, we would talk through the cracks of the door, and there's a small plexiglass window. If someone's sort of laying in the corner, you really can't see them that well. And there are these little slots that they have for food, and where they give it. A CO might be willing to open up this so you could talk to the individual better, but it wasn't very common. So this kind of just gives you a background on, again, if I'm seeing someone in a single cell and I'm concerned for catatonia, it's going to be really difficult to do a physical exam. So again, like I said, there's literal physical barriers to doing the interview and physical exam. And thus the Bush-Francis Catatonia rating scale can't be fully completed, and lack of privacy, as I mentioned several times. In the correctional setting, there's a lot of lack of supportive information. So there's no close observation by staff, minimal, if any, documentation. And again, this documentation is not done from a clinical perspective, but from the correctional officers. So sometimes correctional officers would be able to tell us, oh yeah, this person, hasn't been eating. But a lot of times it was, we weren't sure if they were eating or not. And then, like I said, these are not clinical staff. These are, correctional officers. The exception would be in the infirmary, in which they would have 24-hour nursing, but the capacity in the infirmary is limited. So not many individuals are there. And it's also very highly unlikely that you're able to obtain collateral information from family about, this person's mental health history, if they have a history of catatonia, things like that. And again, we always, we use the supportive information to help support diagnosis of catatonia oftentimes. Refusal of care, the rate of refusal of care in general is extremely high. And so if an individual is not engaging in care, there's a really high threshold for concern. And so that makes it difficult to know, if someone's not engaging in care, is it just they don't want to talk to us? Or could it be something more serious like catatonia? If someone's refusing treatment, there is a process to get court-ordered medications, but again, it's a whole process. And even the most acutely ill patients that we saw there, so actively psychotic, were only seen by a psychiatric provider once a week. That was sort of the bandwidth that they had. Number of providers to the number of individuals need to be seen. But my point in this is that if someone refuses care just once, it's hard to tell, why, or if they're going to do it every time. But if they do that for 3 weeks in a row and there's some other signs that are concerning for catatonia, then maybe after 3 weeks, you might say, maybe we should treat the catatonia, versus if you see them 3 days in a row where they're refusing care and you have those signs. So it leads in a sort of a delay in diagnosis, and also, again, treatment if they're refusing treatment for catatonia. There's a whole process for court-ordered medications. And this is not based on sort of law as far as I know, but how the correctional system and the court system has decided to work. But I think the biggest things are that the person has to be deemed incompetent to stand trial, which has its own process that takes time anyway. So someone could be floridly psychotic, refusing treatment. But if they're not deemed incompetent, then I can't go to start the court-ordered medication process. The charge has to be a Class A misdemeanor or higher, which higher would be a felony, and in Texas, a Class A misdemeanor is punishable up to a year in jail. For example, Class B misdemeanors, which is the next lowest, which would mean that you can't get court-ordered medications, is 6 months in jail. So someone could be held for up to 6 months in jail, floridly psychotic and or catatonic, and as long as there aren't any obvious signs that they're, significantly deteriorating physically, then they won't get treatment. And then the other things are kind of self-explanatory for someone on court-ordered medications. And then again, there's another process for how you have to file paperwork if you want someone to be on court-ordered meds. Physician testifies. And so as you can see, there's a lot of barriers to getting court-ordered medications in someone who may need treatment. So challenges of the Ativan challenges. So how medications get dispensed at the jail I was at was that nurses would go from block to block dispensing medications. And because of this, there was not, it was really hard to tell when patients would get medications. So it would be very unfeasible to sort of order like a one-time dose of Ativan and stick around to see how they respond to the dose, because they might not get that dose of medication for hours or maybe not even till the next day. And again, even for regular scheduled medications, there's great variability in the time the medication is given based on staffing, logistics. I wrote here, commissary is king and medical providers come last in the hierarchy, because that literally, like, we would try to go see patients and commissary would already be on the block, and we would have to come back later because, like, no one's going to come see you if commissary is there because they need to get their commissary goods. And again, if catatonia is suspected, we would start Ativan and then see them in a week and see how they're doing. So that's not really a true Ativan challenge. Issues with continuity of care. Again, how quickly is someone going to get seen? If a patient's taking medication for mental illness at the time of arrest, abrupt medication withdrawal can precipitate catatonia. And I actually found a case report, and there was an individual who had 3 repeated episodes of catatonia due to sudden clozapine withdrawal, and they repeatedly presented to the university hospital from jail due to catatonia. And so some of these instances, I think, were exacerbated by being incarcerated and not being continued or restarted on clozapine. And there's lack of close follow-up upon release. So we don't give prescriptions for medications when they get discharged, like someone does, or when they get released, like when someone gets discharged from a psych hospital. We don't know when they get released. So, someone's on TID dosing of Ativan for catatonia, they get released. We have no idea of being able to follow up that patient to make sure that they continue getting their medication. And there's really not a clear protocol for determining when an individual gets care in the infirmary versus being transferred to like a hospital. For ECT, there's not ECT at actual correctional like systems, but there are cases of individuals being referred to psychiatric facilities for hospitals for ECT treatment while incarcerated, but it's highly underutilized. In the Journal of ECT in 2015, a nationwide survey found that 4 correctional systems out of 31 nationwide that responded to the survey had utilized ECT within the last 5 years. And most of the reasons for why ECT is not used is due to ethical and legal concerns and also logistical concerns of getting someone to ECT several times a week. That would take, several officers to transport them to and back from wherever they're getting ECT. I pose a possible solution of intensive mental health units. So when I was doing research about catatonia in incarcerated individuals, it was very limited, but there was a letter to the editor in the American Journal of Psychiatry in 2004, in which Dr. Niedermeyer had described 3 individuals getting diagnosed with catatonia while residing in an intensive mental health unit within a juvenile correctional facility. And I think the number of individuals total that I was able to find about catatonia in correctional system was maybe like 8 or 9. So this was like a third of the cases. And then later they had published a article describing that they had a 12-bed intensive mental health care unit that they created. And this created, they had the ability to treat those who would maybe usually require inpatient admission for 24-hour nursing and one-to-one monitoring if needed. And so kind of my point with this is I don't think it's a coincidence that there was 3 individuals that had catatonia in this intensive mental health care unit. I think that that's probably going on currently. We just don't know because we don't have that level of monitoring and level of care that these individuals really do need. And those are my references. Thank you.
I'm Soumya Sivaraman. I'm one of the associate professors in the Department of Psychiatry at University of Alabama at Birmingham. And I have no disclosures. So I would be talking about the barriers to ECT treatment in catatonia. So as previous presenters have covered, catatonia is a complex syndrome that presents with a wide range of psychomotor abnormalities. Diagnosing it is challenging clinically, particularly in medically ill, in patients with overlapping neurological conditions, and those in end-of-life care. This is further impeded if they are in correctional settings that add another layer of difficulty in making the diagnosis. So my portion of the talk is focused on barriers to ECT in catatonia treatment, specifically in consultation-liaison psychiatry setting, with a focus on legal barriers to the treatment with ECT. So let's look at the barriers in the CL setting first. So in theory, these are straightforward steps in diagnosing catatonia, right? Is this catatonia? If so, is it benzodiazepine responsive? If not, is the patient medically stable to get ECT? And if stable, is there access to ECT? But in CL psychiatry, each step becomes more complicated, especially when ECT is necessary. So one of the barriers that comes up is the coordination between 3 teams who are going to be involved in the care of this patient. That would be the primary medical team, the psychiatry team, and the ECT team. And as we all know, that whenever multiple teams are involved without a clear process, delays and miscommunications are inevitable. Like basic questions come up. Does this patient need ECT in ICU? Like say someone who has neuroleptic malignant syndrome or malignant catatonia who needs an ICU level of care. Can we transport the ECT machine to the ICU and do the ECT in the ICU setting? or can they be safely transported to the ECT suite or PACU or wherever the ECT is being done? Like, who's responsible for entering these ECT orders? Is it the primary team? Is it the psychiatry team? Is it the ECT team? And especially when we withhold medications on the day before ECT, like if the patient has been on a high dose of lorazepam and still not responding, and the patient needs ECT, and this lorazepam is going to be a barrier in the patient getting seizures, so we may have to hold the night dose. Sometimes we hold the morning dose, and sometimes reverse it with flumazenil during the ECT treatment. So who makes or who enters the orders, and how are the nursing teams included and informed in this process? Because they also form a big part of the patient care, especially when there is nasogastric feeding involved. How do you keep them NPO overnight and things like that? So as we see, even in a well-resourced hospital, these unclear handoffs to treatment can cause delays. So this is, we can illustrate this with an example from a case report by Torika et al. In 2023. So this was a case of a 25-year-old African-American male with schizophrenia who developed malignant catatonia while hospitalized in a community psychiatry hospital that did not have ECT services. So he was on a very high dose of lorazepam, 36 milligrams in divided doses with no response. He had been on Haldol, which resulted him in developing neuroleptic malignant syndrome, so which was stopped. There was also mood stabilizers involved in the picture, but his symptoms did not remit. It took 148 days before he was finally transferred to a facility with ECT, and after 14 referrals. So they had to refer him to 14 different facilities before he could get transferred to a facility that had ECT. And he rapidly improved with 12 ECT sessions, but the patient still had to travel around 5 hours out of county to get his outpatient ECT. And they found that at the end of 2 years, his catatonia was still in remission. This case clearly highlights how institutional limitations and lack of access to ECT can dramatically prolong suffering and care. So why was this transfer so difficult? So let's look at some data. Like 1 in 10 hospitals in US offer ECT, and access varies widely by region. Like in New England, you have 6.4 ECT providers for 1 million patients, whereas in West, South, and Central US, there's 1 ECT provider for 1 million patients. That disparity has enormous implications for access. So now you might wonder, why don't we have more hospitals that establish an ECT program? So there was this 2020 National Survey of ECT providers that was nationwide, and they identified several barriers. First was a lack of well-trained colleagues. In that sample of survey respondents, what they found was 1/3 of the ECT providers were from 12 residency training programs. So basically, lack of ECT training in residency results in lack of well-trained colleagues or psychiatrists who are like comfortable doing ECTs. Second is ongoing stigma among people and even among clinicians, the stigma for ECT and referral to ECT. And then logistical challenges within the hospital, like where do you find the space? Like, is ECT going to be part of the surgical services? And how, if that is so, how are we going to integrate our patient flow into the surgical patient flow? Like, how do we do the check-in, the transportation to the procedure room, and then PACU monitoring, and then this discharge? Or can the hospital have a specified ECT suite where the ECT can be done? All of this combines to make starting an ECT service a daunting process, even in large systems. So the next part of my talk is going to focus on state regulations. Beyond infrastructure, there's another major barrier, state level regulations for ECT. ECT is one of the most heavily regulated medical treatments in US, and laws vary dramatically from state to state. The state laws focus on age, the number of treatments that can be given during a particular period of time, informed consent, specifically what happens when the patients lack decision-making capacity to pursue ECT, who can prescribe and perform ECTs, and administrative requirements like fees, reporting structures, etc. We'll be mainly focusing on the first 3 points about the age, the number of treatments, and the informed consent, the laws focusing on that. So 21 states have laws defining ECT access for minors. Maryland, New Mexico, Rhode Island have no age-based restrictions. On the other hand, California does not allow ECT below the age of 12 and Tennessee below the age of 14. So if you look at the states, this is from the Miller et al. Article, you can see that California, Tennessee, Colorado, Idaho have like very complicated processes, even if the patient needs to get ECT, or they absolutely cannot do ECTs in the states. So you can see what we see now in this slide is the real world impact of the age restrictive state laws. So there have been multiple case reports. So let's talk about this 10-year-old girl who was reported by Evans et al. She had a developmental disorder and treatment-resistant catatonia, who failed high-dose lorazepam and amantadine. Her clinicians recommended ECT. Her parents consented for ECT, but under her state laws, she was not eligible for ECT due to her age, even in a life-threatening situation. So eventually, she was transferred to University of New Mexico, where ECT was legally permitted. She improved and was eventually discharged on a maintenance treatment. This is an access to care crisis. Another 15-year-old with autism and catatonia had been receiving ECTs in Michigan, but her family moved to Texas, where she was not eligible for ECTs until the age of 16. So her treatment was interrupted. In another case, a 65-year-old man in California with recurrent psychotic depression had already reached state's limit for ECT sessions for that year. So he had to fly to Massachusetts to continue the care. So these laws often do not reflect the clinical realities, and they actively disrupt treatment. So when you look at the number of treatments, like we saw in the last case example, in California, you cannot do more than 15 treatments within a 30-day period or more than 30 treatments within a 1-year period. If you have to exceed that, a prior approval must be obtained from a review committee of the facility or the county, where the maximum number of additional treatments can be specified. So this creates an issue when we do the ECT taper, like we do the acute series, we go to once weekly for like a month, and then we try to taper off the patient to every other week. And this is to make sure that patients don't relapse after an acute series of ECT. And this is very dynamically determined. There are some patients who may do well on a weekly, and when we move to every other week, they start having relapse of symptoms. And then we move to like weekly for a few more weeks before we go to every other week. So those dynamic clinical-based decisions may become very complicated when there are restrictions in the number of treatment. In Texas, not more than 15 treatments in an 8-week period or 24 treatments in a 12-month period. If you have to exceed, you have to have concurrence of a qualified psychiatrist who's not involved in the patient's care. These laws are great to make sure that we don't abuse the treatment and the ECT is used in the right setting, but we can also see the downside of it causing interruptions to patient treatment and access to care. So what happens with the state laws when the patients lack decision-making capacity? And it's more common in catatonia that patients who are catatonic and where ECT is necessary in a CL setting, most of them lack decision-making capacity to consent for the ECT. So state laws vary, with some states having no clear guidelines, to some having who rely on advanced directives. Some rely on courts to appoint guardian. Some, you can have a surrogate decision maker. So this case illustrates a 31-year-old woman with developmental delay, epilepsy, and psychiatric history presented with escalating aggression and later developed classic catatonic symptoms. The initial treatment with benzodiazepines were ineffective. Aripiprazole was added for augmentation. ECT was clinically indicated, but was denied due to Oregon state laws prohibiting ECT for patients without decision-making capacity. The patient had a 61-day hospitalization, needing nasogastric feeding, UTIs from multiple urinary retentions due to delayed treatment. But she ultimately gradually improved with lorazepam, but the recovery was prolonged and complicated. So what does the evidence show? Like, what is the evidence for what is the outcome for patients who get ECT when they don't have decision-making capacity? So there was this recent systematic review and meta-analysis that was published by Takamiya in Brain Stimulation in 2022. They reviewed 41 studies, including 7 observational studies that were suitable for meta-analysis. The primary outcome that they looked at was clinical improvement, and the secondary outcomes were cognitive effects and 6 months readmission rates. There were no difference in 6 months readmission rate, but they also showed that the patients who lacked decision-making capacity tended to be older, more severely ill, and more likely to receive bilateral ECT. And patients can regain decision-making capacity and consent for further ECTs. ECT was even more effective in patients without DMC or decision-making capacity when compared to those with decision-making capacities. And all 29 Catatonia patients responded to ECTs based on their analysis of a case series and case report, which was a qualitative analysis. So with proper safeguards, ECT remains a life-saving and autonomy-restoring treatment for severely ill patients who are unable to consent. So we see that there are multi-level barriers to treatment of catatonia. One is limited hospital infrastructure, regional disparities in ECT access, inconsistent state laws. So this inconsistency in access means where a patient lives may determine whether they receive life-saving care. Together, these barriers result in prolonged hospitalizations, worse outcomes, and avoidable sufferings. So what are some things that we can do? Maybe develop standardized protocols for ECT referrals in medical settings. ECT training and psychiatry residency programs to improve comfort and awareness. Advocate for regulatory reforms that ensures medically necessary ECTs accessible, and have like referral pathways between facilities. Say, if you know that if you don't have ECTs, go ahead and try to plan for referral pathways that are existent. So when you have a patient, it's easy to make those referrals and it doesn't delay care. So that's the end of my presentation. Thank you, everyone. And these are my references.